I'm Dr. Alicia Kleinman with the Center for Healthy Aging, your local geriatrician, and today we're going to be speaking with Dr. Blake Herron, discussing dementia-related behavioral problems. Now, Dr. Herron, you have a really interesting training background, if you just want to give us a quick update on it.
Thank you. I'm board certified in internal medicine as well as psychiatry, and I trained at the Medical University of South Carolina in Charleston. With geriatrics being at times, unfortunately, a mix of both medicine and psychiatric issues, and dementia being a prime example of that, I feel like that training sometimes comes in handy.
Oh, absolutely, absolutely. So why don't we jump right into it? So I think that one of the most common questions that I get when people are talking about dementia and what to expect is, how do behavioral problems in dementia typically present?
Well, interestingly enough, they're not always jump right out in your face kind of presentations. Unfortunately, sometimes the first signs of a change toward a behavioral issue in dementia can be depression. Just not feeling well, having more episodes of crying, having some difficulty with sleep, appetite not being good. The things that we normally write off, so to speak, as depressive symptoms. They very much can be kind of a signal that things are starting to shift. Anxiety is another one that's very important to not dismiss as just, well, that's the way she can get, or that's the way he can get. It can be a signal that things are changing, especially if anxiety starts to increase dramatically. Other things, and I don't mean to put this indelicately, but sometimes a shift can be signaled by the fact that we're seeing things that embarrass us personally as family members or caregivers, things that would be out of character for that person to do, say in public or in a private situation even, that would not typically be done, can be a signal that we're moving in a direction where we might need attention.
So, those are kind of the early signs. What about later on? How could those behaviors progress to?
They certainly can progress to things that are aggressive, where agitation becomes more physical. And we notice that as caregivers, for example, our loved one is now grabbing us or holding on tightly and maybe even threatening us to hurt us, to harm us, or to harm other people. Those are signals that we've reached a point where we might need to talk to someone about more advanced care.
So how common are dementia-related behavioral problems?
Well, unfortunately, they can be very common depending on where we are in the illness. And that's something that I would urge people that are asking that question, is this something that I'm seeing, a shift, to not feel guilt, shame, or just inhibited, because that's something that might get in the way of them getting the help they require.
Now, as doctors, of course, I think the public really views medicine as our first line, but really as a geriatrician and a psychiatrist, that is not the first line. So what are some non-medication things we can do?
Well, first of all, the biggest thing that we can do is use our knowledge of the person that we've been with or that we know so well as caregivers, and try to see what sort of context things are happening. One thing that might happen very commonly, for example, is repetition. People asking the same questions over and over again. Sometimes we can, as someone who knows that person, we can stop, take a second, try to see the context that these things are happening in, and making interventions that are appropriate. For example, just redirecting that person, answering the question, even if it's the 1,000th time. Sometimes that becomes difficult. So putting up an answer to a repeated question, sort of in written form, somewhere where that person, if they're still reading, can see, so that they're reminded that that question, they have an answer to that question. Routine can be a real helpful thing too for folks, not going outside of a routine. Having a bedtime ritual, for example, for someone who's having difficulty with sleep at night can be a wonderful way to sort of put them in the mood to go to sleep, just like we do with our kids at night. Reading stories, taking a bath, having a sequence that's comforting can sometimes be a wonderful way to intervene when we're having issues around sleep time and getting calm.
What about situations like Capgras Syndrome, where somebody comes in and they don't recognize their house and they're constantly asking when they're going to go home, when they're actually in their home?
Well, sometimes just handling the question in a way that's not alarming for that person, like, reassuring them that they're in a safe place, that they might go home, later, for example. That can delay a question. Sometimes it can create issues, I guess, by itself, but just reassuring them that we're in the right place right now, we're waiting on someone, we're getting ready to do something. Kind of narrate as you go along to tell them what's happening, because that can decrease anxiety. Because Capgras Syndrome, for the example you just gave, where someone believes that their environment has been replaced by an exact replica of the place they think they're going to be, or with people that they recognize but are different. It can be very much reassuring that you're just going about your normal business. We're getting ready to do this, we're getting ready to do that, and it can be helpful.
How about when people are asking about relatives that have passed away? How should family members approach that question?
Well, first of all, just not saying, well, she died X amount of years ago, because that can be shocking for someone and very distressing, even if it's the 5th time you've just told them that. Because very often memory has been affected. I mean, that's one of the signal issues with dementia, not the only one, but one we commonly associate with dementia. And just reminding someone that, I miss them. I wonder wonder what they're up to. Just sort of gently guiding them around that. I miss them too, or I would like to see that person. That way you're able to say, something not deceptive, but not also alarming to that person.
How about behavior modification with environmental changes like music therapy, aromatherapy? Is there anything to support that?
There's quite a bit of evidence to suggest that those things can be helpful. Reminiscing is one that's also very helpful to help sort of focus and help someone see people that they might be familiar with, and kind of walking them through. And that can also be part of a routine. And it's also a nice answer to the questions that they might have about people is, oh, well, they're right here, and that could be a very nice distraction and a segue away from, oh, that person died. But rather, here they are, and let's go through and talk about that. It's very often very helpful. Even if they don't recall the scenes depicted in pictures or books, they may have a familiarity that outlasts their memory, if that makes sense.
Absolutely. That's wonderful. So now going to when these things don't help, sometimes these behaviors can't be controlled and people are physically or verbally aggressive. What are some safer medications that could be utilized?
Well, first off, I love the fact that you said safer, because all medicines, depending on the context, have the potential to either be safe or to be problematic, especially depending on what you're already taking. So I'd throw in that caveat. Everything that you hear about as quote unquote safe also has to be considered in the context of the medicines you're already getting. And that's why having geriatricians and trained professionals look at your medications when we're talking about that, because everything that we do going forward has to take that into consideration. But things that I think of as safer that can help with agitation, for example, are antidepressant medications like SSRIs. they're very often helpful in terms of decreasing anxiety, decreasing depressive symptoms like we talked about earlier, but also in helping to a small degree with some agitation. Some medications that help with sleep, for example, also can be, there's definitely more bad or unsafe medicines in that camp than there are good, but there are some, trazodone is an example of a medicine that has been used very safely for years to help people with sleep issues that very often can be safely combined with other medicines. And most recently, there's a new medication that's been FDA approved for sleep issues called Belsomra. Again, it has some side effects that have to be considered for patients, but it's actually had some study that informs its use now. And so that would be one that I would say might be helpful, but also has to be seriously considered. And we also have to have feedback from whoever's getting it, the family and the patient themselves, about how things are going once that's been prescribed. Lastly, I've used with some good results with agitation, a medication called buspirone, which is helpful to help reduce anxiety, but also may help to some degree with agitation. Again, it all depends on the context, though.
Now, we talked about safe medications. What about medications? Which ones are considered higher risk? And when might we actually use those medicines? Well,
another group of medications that are higher risk for agitation or aggression and behavioral changes, the typical go-to in the community setting, whether it's from primary care providers or other professionals, has been atypical antipsychotic medications. They're also very much, they have risk, in fact, so much risk that the FDA said, hang on a second, we want to make sure everyone understands how much risk is involved. And there can be issues with cerebrovascular, meaning stroke-like symptoms, cardiovascular, heart problems, lung issues, and even death in the use of those medicines. So we don't want to go to them, for minor sleep issues, for example, or for things that can be redirected with those non-pharmacological behavioral things that we were talking about earlier. And so we would really need to see a set of circumstances where we're thinking about harm to self, harm to others, delusions that lead to, or fixed false beliefs that would lead to aggression or physical activity that would put that patient at risk for more harm, or caregivers. And that's something that I think really has to be a group decision, not one that we just talk about like, I'm the doctor, I'm going to make sure that you get what I want you to have. I want to make sure that we're open and honest about what we think this could do, and really about the expectations, because again, many of those medications that are offered, the efficacy rates aren't as great as we would like them to be, to have that risk that they have of potentially dying.
Mm-hmm. Wonderful. Now, one situation, an inpatient geriatric psychiatry stay. I think, we've discussed this before, that is something that is really almost one thought in people's heads when it's different in reality. And so we have patients, family members come in all the time asking, well, can't you just put her away for a little while and she'll be better? But they're quite traumatized by it. So in all honesty, when should an inpatient geriatric psychiatry stay be warranted, and what should people and their families expect from it?
Well, it's warranted when the alternatives have been exhausted, first of all, that we're really talking about, I don't want to say life or death, but serious safety issues are in play. Dramatic harm coming to someone if we don't do that imminently or urgently. That being said, as you mentioned, it is traumatic because they may be in what are called mixed use or multi-purpose settings where they're sharing space with people that have other mental illnesses that may be much younger, much stronger. And I don't say that to frighten people, because there may be, again, a very compelling need to be in that environment. And if that's true, then we want to have the expectation that we're looking at specific things to target, behaviors that we want an intervention for that maybe didn't respond, or certainly didn't respond to non-pharmacologic approaches, or maybe has already failed other pharmacologic approaches. And we're looking to see if we can make some headway in decreasing that person's risk of harming someone or themselves. And the expectation should be that that might be something that can happen quickly, or it might be something that takes a good deal of time. And that again is also considering that that person might be subject to side effects they didn't have before. So the agitation, for example, may be gone, but they may have sedation and not be as alert and not as interactive as they had been previously. And so that can be very disappointing when we have someone go away and come back, and then we see them differently. They're sleeping during the day more often, and those sort of things. And that's what I would say is, when those folks come home from an inpatient psychiatric stay, that the piece of feedback has to be so important. Hey, they're falling now. They're sleeping now. They're not able to interact now. Those are things that we as physicians that are working with you need to understand better and hear from you, because it's not just you come into the hospital, push the reset button, and everything's great when you come back. It's how are they doing when they get home?
So I think that really brings us to the next subject really well. I think a big part of medicine really has been talking about that transition of care, leaving an inpatient setting and entering an outpatient setting. And we've really worked hard on doing that for general medical problems, but there is definitely a disconnect for that from psychiatric stays. So how ideally should that follow-up look, and how can somebody accomplish that in reality?
Well, I would start off by saying, hopefully the facility you're in before your loved one is discharged is helping you with that piece, because ideally that should be happening. That being said, the number of providers in a particular community can be severely limited by the fact that, as a specialty, psychiatric providers are are a smaller population than the general physician population. Also, kind of interesting trivia, the average age of a psychiatrist in the United States is 60 years of age.
You're not 60.
I'm not yet.
Yeah.
But that means that many of those same people that have the expertise are on the verge of retirement. Mm-hmm. And so that's something that we're kind of battling against right now. That being said, the facilities should be helping to try to get you with someone ideally that has expertise with geriatric psychiatry. I also would throw in a caveat that I also am a fan of behavioral neurology. Mm-hmm. And those are folks that actually look at dementia from the kind of the hardware side of things and are able to make similar, if not exactly the same kind of interventions, and maybe have a little, have a more of a medical approach to things in terms of how is the brain affected by dementia, and how are these behaviors responding. And so again, that would be another way to address that and follow up. Of course, I would love it if that would happen within 7 days of discharge. But again, the providers that are trying to meet this need, there are so few of them and they have such a backlog, sometimes it's a little longer than that. But I would tell you that that's important, coming out of the hospital, is to have that arrangement made, so that expectation is, this is the next step after we leave here. We don't have to wonder, well, what's going to happen? Hopefully we'll also have people calling us with appointments or giving us appointments within that 7 to 14 days after discharge as well.
I think, long term as a geriatrician, I'm always looking at deprescribing. And unfortunately, a lot of the follow-up typically lays on primary care providers who don't feel comfortable with titrating down antipsychotics or benzos that were necessary in an inpatient setting. But I think patients, caregivers really need to be an advocate, and after they're stabilized for 6 months to a year, really need to ask for those medicines to be titrated off at some point or at a lower dose for safety.
Absolutely, and I think that it's important to understand that the average length of stay for someone in a psychiatric unit these days is between 7 and 14 days. And that's on the long side of things. And the average length of time it takes for an atypical antipsychotic to take effect is about 4 to 6 weeks. So we're not able to see the whole transition once we start a medication, what's actually going to end up happening with it in another person. So very often, because those effects aren't realized early on, what we see is sedation first. And so we typically see over-sedation as a means of trying to gather control of an agitated behavior. And you're exactly right. Once they come out, they may be completely neutralized as a human being and need to have that medicine brought down back into a range where we're actually seeing the benefits of the medicine, but no longer need that extreme sedation that we saw before.
Wonderful. Now, what as a psychiatrist do you feel is most important for families experiencing this to know?
Well, the first thing is that you're not alone. I mean, I think that that's important to know that like we said earlier, this is a very common issue, and so seeking support is possible. There are people that can share your experience, that understand what you're going through, that know things you don't know, that can kind of be a guide for you, that that's not using all the $10 words and all of the jargon that sometimes we come at people with. But I would also say that that it's important also to remember that the people that they're dealing with, it's not just their body that's still there. There are elements of that person that you have to sometimes reach back into yourself to kind of gather so that you can see them as both who they were and who they are. Because I think that there's sometimes the feeling that my mom, my dad, my brother is no longer there. That can fuel agitation, aggression, from the caregiver side as well, forgetting that they're still the person that you once loved. I think that's an important thing to remember, that soul is still sitting with you, and despite the appearances that to the contrary.
That's wonderful. Well, thank you so much for taking time to sit with us, Dr. Herron.
Happy to. Thank you.
Thanks. And thank you all for joining us. I hope you all enjoyed it.